better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hey guys, I just wanted to take a minute to kind of walk you through some of the things that we do when we look at scans and CTs for families. So this is an actual case, so I'm not going to show the facial photos, but I just kind of want to walk you through the way that we're relating our clinical symptoms to our clinical findings. So for this kiddo, you can see molars are erupting. I'm going to walk us back to these symptoms here. There's a history of some snoring, some eye shiners or venous pooling, which is a sign of midface underdevelopment, fatigue on waking unrefreshed, mouth breathing both day and night, open mouth posture throughout life. And these are just some of the little things that we're looking at. So what our goals for treatment are in our office are to not only create space for the adult teeth, but as a side effect, when we make space for the adult teeth, we further optimize the airway size, and that helps with long-term alignment of the permanent teeth. So when we look at what's going on here, what I would point out is, yeah, we've got what we call early mixed dentition. So there's some erupting adult teeth, which you can see here, but there's not room for them to fit. These are baby teeth, baby tooth, grown-up tooth, grown-up tooth. But you've got two grown-up teeth crammed into the spot where two baby teeth used to be. And there's also crowding and overlap of the baby teeth. We can see that here. Like, yes, these are mobile, this one especially, because that's where that little space is. But when we have primary teeth, baby teeth, they're quite a bit smaller, 1.3 times the size. The adult teeth are bigger than the baby teeth by about 30%. And so you can almost see that this adult tooth here on the bottom is as big or bigger than the primary tooth, the baby tooth on the top. So we're really looking at a situation here that's very common. It's called maxillary deficiency. And what happens is the lower teeth will often compensate by tipping inwards. This kid's actually in what we call a crossbite, where the upper tooth is inside the lower tooth, and that's not a great position to be in because, again, the roof of the mouth is the floor of the nose. This is called the palate. And when the palate is constricted, what happens is that nasal floor is compromised. And I think a cool thing to appreciate in this case in particular, you can see there's a palatal asymmetry here. The right side, this is the right, is higher than the left. And what happens when this is all compressed in and pushed up? The teeth are also in that position. So for this child, what really needs to be considered is a round of expansion. We can also see there's delayed eruption, not delayed per se, but slower eruption on the right side of the maxilla and mandible than there was on the left. And part of that is this bone over here is not as broad to allow for the eruption in the pattern we would like to see it. And you can even see like this tooth here is looser than this tooth here. So everything's just happening a little more expedited versus uniform on the left versus the right. Is that a big deal? No. Because if we consider what options could be, and many times what we find too in these cases where there's palatal asymmetry, this tooth is kind of stuck on what we call the CEJ or the cemento-enamel junction of the primary tooth. And so sometimes we'll even see super eruption of this tooth and a tipping in and being stuck of this. So what the problem is a lot of times when we have that, orthodontists traditionally are waiting for the first molars to erupt. Well, if they're stuck because they're coming in sideways, they're not gonna erupt. And that was happening here, but it's pushed its way through, which is awesome because there are times where this can like self-correct, but the reason it happened didn't self-correct. Like this palate is still asymmetric and it's still narrow. It's not narrow compared to the worst of the worst, but it is still narrow. So what does that mean for us? Well, when we look at the CT scan, I think one of the things to appreciate that you can see, and this is what we try to point out to parents, these adult teeth really are gigantic in comparison to the baby teeth. And I highlighted that in the scan, this iTero scan, but you can see it even more so in the CT scan. These incisors still have a way to go. And one reason they're taking a little while is because these roots haven't been in the best position for them to resorb them as rapidly as possible. So is this airway narrow? Well, that's a question you can ask yourself, and we ask ourselves that every day. It depends on positioning in the scanner, truly, because this is a snapshot in time. This is not diagnostic for sleep apnea. It is giving us relevant information to help us guide our treatment. So when we look at this child, what we can see is that there's not a big block of air. Black is air, gray is soft tissue, white is tooth or bone. And you can see how dense this enamel is. It's much brighter than the skeletal bones, which is crazy. I mean, enamel's the hardest structure in the body. So what we can see here is that sometimes we take these scans and there's a big black blob here because there's air and that tongue's just living low. Maybe it's tied, maybe it's low tone, maybe it's just because that's where they had it and the 4 seconds this scan takes to take. But in this situation, you can see this tongue is nearly filling the entirety of the oral cavity. There's nowhere left for it to go. So does this airway look narrow to the naked eye? Not really, but if we're looking at the details, it 100% is. Because this patient is upright and alert. What happens when this child goes to sleep? And also, we have this neck kind of straight up and down here. This is all positioning in the scanner. Is it the wrong position? No. Could it be better? Maybe. Is it a really appropriate image for what we need? Yes. And so what we're looking at, there's a little adenoid enlargement, which is this tissue right here. It's a little gunky. It's not huge. It's not fully occluding the airway. But when this child's laying flat on their back, this airway is going to become obstructed because there's nowhere for that tongue to go except for out and forward, which it's not going to do while we're asleep. So this is the poor quality sleep. This is the restlessness. This is the fatigue. This is the bedwetting, the nocturnal enuresis. This is the sleep talking, the sleepwalking, the vivid dreams, the no dreams. Like the symptoms run the gamut that we see. But really, what are we trying to accomplish when we're talking about these cases is ultimately improving the ability for the patient to breathe by dental treatment. A side effect of lining up the teeth is making a better breathing passage. So the other thing I'd like to point out is we now have literature that supports a high vaulted palate as an independent risk factor for a deviated septum. Well, I showed you that in that scan, that palatal discrepancy, and you can see it here, right is higher than the left, not by much, but by enough. Because what we see here too is what's called a deviated septum. And sure, could that be made worse by something like a sports injury or car accident or whatever? Absolutely. But I think the hard part is if in childhood we never look for the septal deviation, we have no idea how much worse it got. Because this is a piece of cartilage. And if this palate is broad, that piece of cartilage stays flat. If that palate is vaulted, as it is, that piece of cartilage goes like that. We can see this is a little bit of positioning too. There's a little bit of sinus size discrepancy. Is that a big deal? No, not really. Sometimes it can be a big deal when it's supporting the orbit though. And that's where we see a lot of patients who have ocular issues. Maybe it's that the nerves aren't firing as quickly and there's a little bit of an ocular delay with some of the primitive reflexes and things that I am really passionate about looking for. Maybe it's just that the cranial base is asymmetric. And what that means is one orbit is supported differently, leading to a different perception. And we have a lot of our patients that are wearing glasses, and that's fine. Glasses are a tremendous tool. And I'm not saying that palatal expansion will negate the need for it. But I am saying that a discrepancy in the cranial base in terms of size can cause issues with other systems besides just dental alignment. So again, this is a little bit torqued. This is something people are going to give me criticism on. I'm not looking at what is this sinus volume compared to this one. I'm looking at where do I have an opportunity to do what's within my scope of practice, which is put teeth in a better position for a long-term future. So I hope that helps a little bit. There's a lot more that goes into this stuff than just being like, you need an expander. And the hard part that I tell families is, and we treat a lot of families, we treat a lot of like siblings of different ages, and the symptoms are often different and the presentation's often different. Like one kid's got all their teeth and they're spacing from a tongue thrust, and one kid's got a crossbite, and one kid's got both jaws that are crowded. The root cause can be similar. It can be related to tongue posture function, it can be related to environment, it can be related to genetics, it can be related to the food we eat, the air we breathe. It's related to all of it. It's never just one thing. But the root cause can be different. The symptoms can be different. These kids can have different alignment, different things that we're looking at, but oftentimes the treatment can be similar. A lot of this is midface underdevelopment. A lot of this is maxillary constriction, maxillary underdevelopment. And so what we've really got to look at is what is our opportunity while a child is growing to improve the future for them. And I tell people, like, you could argue, sure, it's a life or death issue because there's a link between sleep apnea and shorter and poor quality of life. I don't want to scare people, and I don't say that. I say this isn't a life or death issue. I say this is a quality of life issue, because what person doesn't feel like they have something that they're managing that's difficult for them health wise? Maybe it's anxiety, maybe it's sinus issues, maybe it's true full sleep apnea, maybe it's brain fog. A lot of this stuff can be traced back to structure and breathing. This is the book that I bring up all the time, but it's by Matthew Walker. He's a PhD sleep. And I think the coolest thing about his book, Why We Sleep, is he breaks down so much of our chronic health issues in relation to sleep and breathing. And we can really argue that even with the external factors that are out there that are influencing, we do have controls and tools in our toolbox to help negate some of the issues that our environment has. So maybe the air is more polluted, but if our breathing passages are larger, not smaller, as we know they're going genetically, we will have a better capacity to manage, filter, and utilize that air and oxygen. So there's my 2 cents on CTs and scans, and I'm happy to do more of these if you guys like them. It's kind of fun. I mean, it'd be fun to do an adult sometime just because there's a lot of different things that we're looking at. And, shockingly, like when we do these scans, we uncover some gnarly stuff. Like more recently, my colleague Katie Johnson, who does a lot of joint management, her and I work together as well. We found some pineal gland calcifications, and different calcifications in different spots that are kind of scary. So there's calcified circle of Willis is one of them, and like that's high risk for stroke. So beyond airway stuff, these CTs are incredible in terms of diagnostic, giving us, I don't want to say they're diagnostic, giving us information that helps people get diagnoses that can be life-saving. Like that is a high risk for stroke and death early. And like these people are immediately referred to cardiac because a lot of them need to have it managed, and it may be with anticoagulants, but like this is a 30-year-old new mom. Like you don't want to find this stuff in there. We see joint deterioration, we see carotid artery calcifications, I have colleagues who have uncovered tumors. Like there's some scary stuff out there, and if we can catch things early and treat and prevent, we can make a big difference. So I love the technology that we have at our fingertips. It can be a bit overwhelming, so if you're a dentist and you're watching this, there's a ton of great information out there in terms of how to read these. I think when we're really looking at these details under the tissues and under the bone, we can catch so much more and do so much better for our patients. So have a great day.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this, and don't forget to subscribe.
want to learn more about Airway Health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram at Untethered Airway.
Until next time, bye!